Hello, everyone. It
Hello,
is, how are you guys?
we're good.
It is with absolute pleasure that we host the Fish Tank. And we want to thank you for joining us in this space where our guest speakers will dive into their cases, sharing their experience, triumphs, challenges, and most important, outcomes. I am Marta Hines, Veterinary Business Development Manager at Kerecis, and with me are three wonderful and experienced veterinary doctors that will share their experience with intact fish skin and its use for canine distal limb mast cell tumors and wounds. They are Dr. Andrea Clark and Dr. Astrid Beniquez from VCA Animal Hospitals, who will go over the cases, and Dr. Elizabeth Maxwell, Assistant Professor in Surgical Oncology at the University of Florida, who will co-moderate. Dr. Clark attended Texas A&M University for both undergraduate and veterinary schools. Dr. Clark was accepted into veterinary school a year early, and she was awarded her bachelor's in biomedical science by default after completing her first year of veterinary school. After internships and residencies, Dr. Clark went on to become a diplomat of the American College of Veterinary Surgeons. Dr. Clark has authored papers that are published in both national and international journals and is a member of numerous veterinary organizations. Dr. Clark currently practices at VCA Hollywood Animal Hospitals in Hollywood, Florida. Dr. Beniquez attended the University of Florida, Gainesville, where she completed both her undergraduate and master's degree in veterinary forensics and went on to graduate magna cum laude in May 2023 from Lincoln Memorial University, Richard A. Gillespie College of Veterinary Medicine. She was presented with the American College of Veterinary Internal Medicine Clinical Excellence Award in Small Animal Medicine. She's currently completing a surgical specialty internship at VCA Hollywood Animal Hospitals in Hollywood, Florida. And lastly, Dr. Elizabeth Maxwell is a Miami native that graduated from Ross University School of Veterinary Medicine in 2012. Then she completed a 3-year small animal surgical residency at the University of Illinois and a 1-year surgical oncology fellowship at the University of Florida, where she is currently an assistant professor. Recently, Dr. Maxwell began hosting The Margin, the official podcast of the Veterinary Society for Surgical Oncologists. Ladies, welcome to the Fish Tank. Before we begin, please note that all microphones will be muted during the presentation. However, we want the space to be a collaborative forum and invite you to write your comments and questions in the chat to be addressed after the presentation of the cases. Now, for those who are new to Kerecis, Kerecis is an Icelandic medical device company that develops, manufactures, and sells patented fish skin grafts for wound care treatment and soft tissue regeneration. Kerecis is a two ways to value story. The grafts are manufactured from skin of caught fish left over from the fish industry. The fish are line caught in the cold waters of the northern Arctic Circle and lightly processed using the energy and fresh water from the area's thermal natural resources. The grafts are classified by FDA as medical devices and are indicated for traumatic wounds and burn wounds. All our products are manufactured in Isafjord, the northwest region of Iceland, where we run 2 manufacturing facilities. In addition, we have offices in Reykjavik, Iceland, in Arlington, Virginia, Minneapolis, Minnesota, the United States, and Germany. Kerecis formats are solid, mesh, and fragmented and are available in a variety of sizes. Kerecis solid and mesh are used in partial, deep partial, and full thickness wounds with flat or level topography and scant, minimal, or moderate drainage. Micro, which is our newest product, we will start selling somewhere around the 1st of December, is Kerecis in fragmented format, and it was created to fill in uneven tunnel and undermine wounds. When it comes to tensile strength, Kerecis is a strong graft with great tensile strength that makes it easy to handle and apply with sutures, staples, or medical glue. It only requires 30 to 60 seconds of hydration in saline solution, and you are pretty much ready to go. And now with that, I would like to hand it over to Dr. Maxwell, who is going to go over the science behind Kerecis, and then she will then move us over to Dr. Clark and Dr. Beniquez. Welcome, Dr. Maxwell.
Thank you, Marta. So the great thing about Kerecis fish skin is that you can use it in almost any type of wound. The indications for use include partial or full thickness wounds. So this could be pressure sores, skin ulcers, but you could also use it for traumatic wounds, burn wounds, surgical wounds, and any other chronic non-healing wound. Kerecis fish skin grafts are made from Atlantic codfish. So the Atlantic codfish are harvested from very cold waters in Iceland. And these cold water fish do not have any risk of viral disease transmission to humans or other vertebrate biological species. So it's because of this that Kerecis fish skin grafts go through a very gentle processing. So during processing, the scales are removed, cell lysis is done via osmotic mechanism, and the grafts are sterilized for use. This gentle processing preserves the structure and the biology of the tissue, which further supports tissue regeneration. The fish skin is homologous to human skin, and you can see that here in the slide. There are similarities in the 3D structure of the dermis and the epidermis between the fish skin and the human skin. This similar porosity, size, and arrangement of the tissue structure helps to support cell migration, proliferation, differentiation, and adhesion. Kerecis fish skin and other competitive products were tested for the ability to resist bacterial invasion against Staphylococcus. Results demonstrated that Kerecis fish skin had a longer acting bacterial barrier than the other grafts shown here. And in this preclinical trial, Kerecis was compared to fetal bovine dermis, a product called Prematrix, on deep partial thickness burn wounds in Yorkshire pigs. These wounds were treated with Kerecis or Prematrix on day 1 and day 7, and results showed that on day 14, there was 50% greater reepithelialization, reduced wound size, faster incorporation, and better blood perfusion. On day 60, there was mature healing without contracture in the Kerecis group. Kerecis has invested in research and has completed 5 randomized controlled trials, as well as numerous peer-reviewed articles in the human and veterinary space. So now I'll turn it over to Drs. Andrea Clark and Astrid Beniquez to share a few personal stories about their experiences using Kerecis vet fish skin in clinical practice.
Thank you, Dr. Maxwell. Thanks for having us today. We're
Thank you.
excited to share some cases with you guys, share our experience, some tips, tricks, things that we've learned along the way. So today we are going to be talking about 3 cases that we've recently used Kerecis with. It'll be Max, Casper, and Smokey, and we'll get into their stories now.
All right, so what we have here is basically an image taken from the Kerecis website and a reiteration that it's an intact acellular fish skin that we're using to kind of graft over these non-healing or slow healing wounds. As you see, there's like a little bit of a timeline. You can open wound, manage the wound, and then once you get it to a certain point of healthy granulation tissue, apply the graft, and it really helps provide and support more material and kind of a scaffold for this granulation tissue to fill in the defect. The indications of use: burns, trauma, lacerations, surgical wounds, full and partial thickness injury. That's kind of what we've been using it for as well. So that's what this slide is kind of here to introduce.
Okay, and with that, we will get into our first case, which will be Max. Max is a 7-year-old male neutered golden retriever. He presented to me on April 11th of 2024 for a surgical consult. He had been diagnosed by his primary care veterinarian with a mast cell tumor on the distal limb. They did that via cytology. And he had actually had an oncology consult already when he came to see me because of the fact that This is a mast cell tumor. Typically, surgery-wise, we do need to and want to take wide margins. And it's on a distal limb, which is not a place that has a lot of excess skin to take those wide margins. And so they did have an oncology consultation. They talked about options there, but then they wanted to get, surgical options and have that consult with me. So we did talk to them extensively about, the wide margins, the lack of excess skin, the potential for complications because of that, especially being on the distal limb, and how this may wind up being, a long process as far as his healing goes. But ultimately, the owners did want to go forward with surgery, knowing, these complications were potentially going to occur. The big thing is they really wanted to know the histological grade of the tumor, as well as wanted to see histologically whether or not we did get clean margins. So that was kind of their thinking.
And here we have essentially summary of the surgery report. It was the right carpal region, this distal limb that was, prepared. There was a 1.5 centimeter raised dermal mass, and we did get a minimum of 1.5 centimeter margins taken in all directions. There was noted a certain amount of tension, a lack of excess skin, and then we did do some tension relieving incisions circumferentially around the limb, just to facilitate a pretty routine closure of the area. The owner was prepared and knew that these were considerations for the surgery. And in surgery, we did try our best to do everything possible to reduce the tourniquet effect of the distal limb. So we did note that the paw was warm to touch with no obvious tourniquet effect. A soft padded bandage was placed postoperatively with a caudal splint to support the closure of the site, and then the patient was transferred and recovered uneventfully. Here we have some images that were taken once this wound did showcase its dehiscence, and then tissue necrosis and some debridement was done. The wound bed itself became quite extensive once we had some of that tissue just kind of fail, and you can see very clearly that the paw pads were also having some difficulties. There was some sloughing. There's the releasing incisions that you can clearly see, and you can tell that the distal limb and the paw itself is just very swollen, just pretty angry tissue that we're really having to, debride and then eventually get to a healthy point for our grafting.
So one thing that we did do prior to the graft is we did, get a culture and sensitivity on the wound once the incision dehisced and it became an open wound. We did pretty extensive, as you saw, open wound management, and made sure to get it to the wound to a place where it was healthy. The patient was on appropriate antibiotic therapy based on that culture and sensitivity result. And we did wait to apply the graft until we had a healthy bed of granulation tissue. I didn't want to risk putting on, the Kerecis graft in an infected wound for fear that it, would fail. So he actually had 2 graft applications. This is the image of Max's first graft. And so it was, the main wound where the incision had been that we have placed the graft in. It was sutured, just simple interrupted. It was, we cut it to match the edges of the wound so that it didn't overlap any healthy tissue or skin. So it is directly over that wound bed that contains that healthy granulation tissue. And then we just sutured it to the edges. In a simple interrupted pattern. I did place some slits in the middle of the Kerecis graft just to allow for seepage of fluid from the wound, which inevitably would happen postoperatively. And so this was May 18th. That was the date of his first graft application. And now this is intraoperative images of his second application of Kerecis graft. So as you saw in the prior pictures, and as Dr. Benitez stated, the paw did get very swollen, and because of that, he did lose some of those digits, or not the entire digits, the nails. And he did slough some of the skin over the digits. That skin over the digits was healing very slowly. So once, we got it to a healthy point, I decided to go ahead and do that second graft procedure. And that was on June 6th. And that was for the digits. And just an aside trick, I didn't have an assistant in this surgery. So I learned that Gelpies are great toe spreaders if you need them.
All right, so the following pictures we have, these are some progress pictures that we had that showcase essentially some color changes that we have to the tissue surrounding it. We have some crusting and thickening in certain angles. You can tell that this granulation tissue is exuberant. We did pretty much the same kind of pattern of initial daily bandage changes, days 1 to 3, and then transition to like every other day bandaging, with gentle cleaning, minimal handling of this wound bed as much as possible, and noted strike through, noted if there was any other changes, and used a lot of non-adherent pads for the actual healing process. But this purple color change was something that was noted particularly strongly in Max's case, and it's something that we were just keeping a very close eye on. And you can tell also the underside of his paw itself still retained that kind of like almost pillowy, kind of thickened appearance. So it might be something secondary or completely separate from the grafting, but it's something that we noted in particular in Max's case. And that color change does eventually improve over time. And you can tell there's a very distinct appearance to both of these kind of granulation tissue beds as well.
Yeah, I think the first picture really highlights that purple color change, which I had not seen before, and so something that we closely watched, but it did just slowly dissipate. And you can see in the second picture how it does go away, and it did not cause any adverse or ill effects. So this is a picture of once the graft had pretty much fully integrated. You can see that, the tissue remains erythematous, a little bit thickened. There's definitely a change in the hair growth pattern, but, the wound is healed, and the patient is walking on the limb without lameness or pain. So at this point, since the graft was fully integrated, and this was roughly 4 weeks after that second grafting procedure, I did decide to go ahead and transition him at this point from our bandages that we had been doing to a protective booty, so that, we just got this to heal, wanted to protect this work, especially when he would go outside, things like that. So didn't want anything to happen to this freshly healed wound. So we did get him a special booty that he wore for a period of time. At first, all the time in the house and outside, but then transitioned to just outside. And now he doesn't need to wear it anymore.
And so here, what we have is roughly an image is 2 to 3 months. I think honestly it was closer to 3 months post graft, and pretty much after that last picture that we were seeing too, we are seeing that he has this chronic change to the skin where it didn't really regrow the hair. It's something that we were somewhat expecting. He does have a strange kind of hair growth pattern, but his skin is just a little bit thickened in appearance, just generally in the side. He did represent with like a nail bed like infection and a little bit of an onychitis with some seepage. And it was noted also that he developed these kind of thickened nodules kind of at the base of his nail bed. So this could be completely separate to the grafting, but it's something we still noted in his case in particular, just because it could be a secondary like inflammatory change. I believe the dog himself also has some allergic dermatitis issues where his skin does tend to flare up. So just something to note, but it had nothing, large clinically. It wasn't a large impact to him, and he was still using this leg pretty well as well.
Our guess is that those nodules are probably secondary to him sloughing those nails in the nail beds, and this is kind of how it regrew in his case. But again, it didn't seem to bother him.
Yep.
So now we move on to our second case. Our second case is Casper. Casper is an 8-year-old male neutered German Shepherd dog. He presented to our emergency department on June 30th. He had initially gone to his primary care veterinarian for acute onset of lameness of, unknown origin, unknown cause. He's a very hyper dog. There's another dog in the household, also a German Shepherd, younger than him. Both are very exuberant players. So the RDVM did do some x-rays and found that he did have a fractured phalanx. So they placed him in a splint and bandage. The owners were, traveling, and so as caretakers at this point, taking care of the dog. And again, he's a very hyperactive dog, history of allergic skin disease, and also has a lot of anxiety.
So what we're seeing on this slide is basically the bandage as he presented to the emergency. He had this fractured toe. The story was that he was under the watch of the caregiver, and the caregiver did try to replace the original bandage that the RDVM had actually placed. He was potentially apparently running around the pool, and at some point was noted to have got into the bandage. And then you could see visibly that, when he got through the bandage, he did in fact get to his skin. So there's definitely a behavioral component that we have to keep in mind here for him. And we went ahead and removed this bandage to showcase kind of what's underneath the next slide. So looking at what he's got underneath this bandage, he's got this blebbing necrotic tissue that's really just kind of expanded, it's floppy, he's got really compromised skin, and it was necessitating extensive debridement. Essentially, it traumatized the site. It was still painful on his fractured phalanx at this point. We did initiate the collection of the culture and sensitivity sample, started some antibiotics. And the biggest thing for him is that he initiated medical boarding in the particular case that his owners needed a way of keeping him confined, and also needed him to be under really close supervision for this to really help him. So he was started on gabapentin, trazodone, and aceclomazine and kept in hospital. And this was a very, very important thing to know, because it is something that has facilitated us, being able to actually move forward with eventually debridement and then evaluation of these lesions.
Yeah, we were glad that the owners at least recognized the fact that they wouldn't be able to be compliant. And so they did agree to board him with us.
So what we have here is some images that we have of one of the moments where we were debriding some of this very unhealthy tissue. And we have essentially some of the lesions, anatomically that you're going to be seeing later do get addressed with this grafting. He's got this dorsal wound on digit 3, on the axial aspect of digit 1, and at axial aspect of digit 2, there's this interdigital sloughed tissue there. On the dorsal aspect of his metacarpals, on digit 1 and 2, there's this large lesion there. And then on the palmaro-medial aspect of the skin along the metacarpal paw pad area, that last image, you're seeing another large defect there. So essentially, we were really concerned about what's going to happen to his paw pads on the palmar aspect of his paw, and we were concerned about how we were going to get these tissues to really fill in and bridge the gap between the skin there, and eventually get this tissue a lot healthier with the use of antibiotics and open wound management. This is another example that we have here of how large this defect was on the palmar aspect. And you can see that it's kind of encroaching on that paw pad. We did do more debridement after this because there's still a little bit of unhealthy tissue in that wound bed. But we started asking the question at this point, how long is this going to take to really close? We were upfront with the owners after various sessions of open wound management and bandage changes. And the owners had the means to do it. So we did elect to move forward with continuing more open wound management, getting this wound bed healthier, and then eventually doing a graft application. This is the palmar aspect of the paw. If you go to the next slide, we'll be able to see the dorsal aspect. So you can see there's quite a gap there on that metacarpal area.
And there is bone exposed, and there was bone exposed at the time of the graft placement. So this is images of Casper after we have placed the graft in the various wound beds. These are anywhere from days 1 to 3, all the different sides of the paw. You can see where the paw pad was. We did place the graft in that area of where the paw pad was. I didn't know, exactly how that would work out, but was hoping that it would somehow help to get that paw pad to re-epithelialize and heal. So then we continued with bandages after this. So this is day 2. One thing I did differently in Max's case, or I'm sorry, Casper's case compared to Max, is that with Max, I just used a dry Telfa over his graft. But with Casper, I decided that I would place some hydrogel and then a Telfa. I do feel like this it did not lead to good effects, and it did lead to a delay in healing. Ultimately, as we go through the remainder of his case, you'll see that we, got him to heal, but I do feel like the hydrogel, you can tell in the pictures, it made the graft kind of soupy and just jelly, gelatinous, and portions of it were just kind of falling off. And like I said, this was just day 2. So at that point, I decided, okay, no more hydrogel. We're just going to do dry Telfas and our bandages and see how things go. But I do feel like even though we did ultimately get, good results with healing, the hydrogel did lead to a delay. So here are just some progress pictures that you can see on the different aspects of his paw. You can see, the dorsal aspect along the digit. They all are, healing, epithelializing. Even the paw pad, I was really happy to see, progress with the paw pad. That I was probably the most worried about that area. But the next slide will show some more progress. And so at this point, he's almost completely healed. The dorsal aspect is healed, just small, superficial area in the palmar aspect. But he has a paw pad. He's using the limb, not lame. So I was very happy at this point with those results.
He was regrowing hair fast, because I remember this was only like 3 weeks out too.
Yeah, yes, and he did regrow his hair. That is a good point. So as I did with Max, at that point, in the prior slide of those pictures, I decided, okay, let's transition him from those bandages and bandage changes to a protective booty, like I had done with Max. However, Casper is a unique patient and decided to give us some more challenges. So he not only chewed the booty, but chewed through the booty and got to his paw. And so this is just another, highlight of each patient is individual. We had some more complications because of that at this point, but we'll explain how we got through his case.
So this slide is really showcasing, so on presentation, we had originally cultured 3 different organisms. We had some Enterococcus, had some Staphylococcus pseudointermedius that was not methicillin resistant, and then Klebsiella. Those were the 3 organisms that we had originally targeted with antibiotic therapy. We had started cefovecin injections, convenia, and then marvofloxacin based on this original culture result. However, when he presented with his paw booty and the skin color change and like his kind of licking habit, we did reculture him. I didn't attach the culture result of the second one because ultimately it was really multi-drug resistant. So most of the normal options that we would use in the hospital, I remember it being susceptible to amikacin, chloramphenicol, and gentamicin, and he regrew methicillin resistant Staphylococcus pseudointermedius and Pseudomonas on the second culture. And so that kind of just opens the door to always keeping in mind that your original culture results, you want to stick to them and do treatment diligently based on that. But if you notice a skin change or you notice a behavior change in your patient, maybe there's now an itching component or some level of a redness or erythema that wasn't there previously, might be a good idea to reculture, just make sure that we're not missing something else. And it could even be something resistant that then really changes the question of how are we gonna kind of approach this? So that's what this slide is really important to think about. So at this point, Dr. Clark was actually out of office, and so he presented with this redness. We elected to really just remove this paw booty and take a quicker look at what was happening there. And we did and basically consult with our dermatology service. Our dermatologist here, she's excellent at thinking of utilizing topical therapies for these kinds of multi-drug resistant treatments. And since the skin didn't have any open lesions at this point, we spoke to the owner about what group, but we went ahead and elected to continue on with what we had going on with the medications, the marlofloxacin and convenient until gone, and then initiate doxochlorohexidine shampoo, and then also the S3 Pio product wipes to help the superficial pyoderma out. And then the larger question here is how are we going to control his behavior, his anxiety? So we continued with his chill protocol, gabapentin, trazodone, and acepromazine to the best that we could. But then on top of his e-collar that he could use now to get to this, we apparently found a way to get to the foot with. We also initiated a donut collar to kind of go behind that e-collar so he can't push it, as well as he did go home with instructions strictly to try basket muzzle. And then essentially do the soaking treatments and see how this heals.
So these are the final pictures of Casper. You can see with the help of the dermatologist, we got good control of that skin infection. All his wounds are healed. He's using the leg well. He's no longer licking at it and causing issues. He no longer is wearing a boot, no longer is wearing e-collars, is back to being normal Casper. Still naughty, but at least he's healed. So then we have case 3. Case 3 is Smokey. Smokey is a 5-year-old male intact pit bull. He presented to the emergency department initially. He sustained an injury while he was fiercely trying to dig under a fence at a possum, and sustained injuries to the nails on a few of his digits, including the nail beds. That's initially what he came through the emergency department for, was he was bleeding profusely from those exposed quicks. The emergency department did get control of that hemorrhage from the quicks, placed a bandage on the paw, gave the owner instructions, to remove that bandage in a few days, which the owner did at home. And the owner then proceeded to take a nap. And when she woke up, Smokey had been licking and chewing at his paw, causing a big open wound. So back to the emergency department the owner goes, which is where we will pick up on the next slide.
So on presentation, he represented to the ER and actually saw me because I was doing my ER shift of the week. The injury that we have here is pretty much how it looked when he came in. He had this dangling, slightly, compromised subcutaneous tissue that's just exposed. He had tendon exposure, and there's very much a gap that we tried to kind of see if we can reoppose. I spoke to the owner extensively about the options, and we had talked about open wound management, treating this open, or attempting to close some, if not all of it. There's not a picture for the closure because the closure didn't last very long. We did try to close it with some releasing skin incisions, and the next day the patient presented with, a bandage issue, and then also we had noted that the incision had actually failed. So essentially, this is what we were working with. Once the incision failed, was we trimmed the tissue and ended up having to do further debridement.
So initially, the owner was offered surgical consultation numerous times throughout these emergency visits, but due to financial constraints, had declined every time. Even they had tried to get the owner to let them collect a sample for culture and sensitivity, which was declined. So he was just being treated empirically with antibiotics that, we didn't know if it was effective against the bacteria present or not. But eventually, because of how extensive the wounds were, or the wound was, and because of the fact that the initial incision did dehiss, the owner did go ahead and approve a consultation with me. So we did do that consult. I did insist that she let us submit a sample for culture and sensitivity because, again, I don't want to be either doing open wound management with an infected wound or considering placing a graft an infected wound. So we did do that culture sensitivity. We got Smokey on appropriate antibiotics based on those results. And then, at first we did just, more aggressive open wound management until we got a healthy bed of granulation tissue, at which point, we had talked to the owner and already come up with the plan of using the graft once we got a healthy granulation tissue bed. So this is a picture of Smokey immediately post-op after we placed that graft. Even though his wound is smaller than Max and Casper, he has a lot of behavioral issues. And so part of the thinking with this patient is like, we really need to get him to heal as soon as possible. He does not do well coming to the vet at all, which we'll get into further. But so our hope was that, this would facilitate faster healing with a good outcome and get him back home where he's not having to come in and see us every day, every other day. And so here are some progress pictures. Initially, we did daily bandage changes with him. Then, went to every other day, just depending on how effusive the wound was. That's how we decided, when to start gradually increasing the amount of time between these bandage changes. He healed quite quickly. I was very pleased with the progress. And this is about 2 weeks post-op, at the bottom picture. And you can see how it's already almost fully epithelialized, not quite there yet. But at this point, we were already thinking about, do we need to make measurements for a protected booty for him? Because we are, getting good results, getting nice healing. And so that was in the back of our mind as well. But we did continue with bandage changes at this point. So this was actually last week. We saw him, and at this point we did measure him for a protective booty. You can see there's just a very small area where there's not full epithelialization yet, but it is almost fully healed. So we did replace a bandage. We measured his paw, gave the owner where to purchase the booty, told him to bring it at the next bandage change because, we may be ready to transition to a booty at that point. And then this is him actually yesterday. He came in to see us and he is fully healed, very happy with the results. The owner did bring the booty, which we did, put him in at that point. He's still going to be wearing the e-collar, so hopefully we don't have another Casper incident. But he's doing great clinically, and I was super impressed with the results, super happy with the results.
So what we really need to glean from his case is while he's healing well and doing well and everything, he did have quite a few behavioral indications, complications, if you will. So the bandage changes from the beginning were complicated a little bit by cage aggression and dog aggression, which is why we didn't necessarily jump at the opportunity to offer like a med boarding for him. It was very hard to also work with, I guess, the owner's work schedule as to kind of when to bring him in. And then we did find eventually, okay, so we can minimize his time in hospital by having you come through the exam room. He was aggressive with the cage, so we can't have him in this kind of drop-off fashion. So we transitioned slowly from doing sedated debridement and then, maybe trying oral sedatives. We tried dormocidin actually to see if we can get him, to come in get this sedation on board before he's even in, and then see if we can get him in without having to, one, give this owner another, sedation charge, and then two, also just see if we can get him in, get him sedated to a point where we can get what we need to get done, and then have him wake up or reverse before he even goes home. He did have an episode in the exam room when we were trying to have her come through where he had this almost reactiveness, paradoxical excitation, if you will, on the dormocidin, which we tried just based on other usage that we've used on other patients. So we did eventually transition away from injectables and away from doing dormocidin more to doing a little bit of a chill protocol before coming in. And we even decided to bring him in through the opposite side of the hospital, through the back entrance, where he's not going to see any dogs in the lobby. He's not going to see any owners waiting. He just waits in the car. Someone tells us that they're here. They call the hospital. Someone tells us they're here. Then me or a vet assistant go out. We give them the muzzle. They put the muzzle on, and we bring him in. We do our bandage change unsedated, just on the gabapentin trazodone combination he gets, and then we keep the muzzle on and bring him out. We had an episode where he was doing really well. He was even taking treats. We trusted him a little bit more, and we removed this muzzle, and he did actually try to get protected when we returned him to the owner, and he ended up lunging after Dr. Clark and then lunging after me. We didn't have any injuries from this event. I kind of dropped a slip lead. We made distance with the dog, and eventually the owner regained control of the dog. But this is definitely something that we need to just keep in mind. Since then, he has come through on sedation appropriately 1 hour prior to coming in. He comes through the back of the hospital, has to have the muzzle to enter the premises and leave the premises. And the owner has been, very cooperative and understanding through all of it. And it's something that up front, his aggression has kind of transitioned from the beginning of all of his bandage care to even now when he's in the movie. So something we need to keep in mind for every patient. There might be changes in how we have to manage them behaviorally through all of this as well.
I think a lot of these chronic, like long-term wound, bandage change dogs often reach a point where they're just kind of over the whole process and tired of it. And that can contribute, to some of these behavioral changes that we can see during the healing process. So just a little bit more about the protective booty. Each of these cases, we recommended different protective boots just based on, the dog's conformation, how high on the limb we needed to be protected, that sort of thing. But these are just some pictures of measurements and things that we did. But I do think, especially when, like in Casper's case, a large portion of the wound was on the bottom of his foot where he's going to be bearing weight. And so protecting that in the early period after it's healed, I felt like was particularly important for him, but also, Smokey, we know he likes to lick and chew. Max has a history of allergies too. So, all these dogs are prone to lick and everything at their foot. So until the skin gets a little bit further along, I just like to keep it covered to protect it, to make sure nothing happens. We want to protect our work and make sure we don't go backwards in the process.
Alrighty, so this slide, we just kind of have follow-up, final thoughts on everything, just to introduce, we're both going to kind of talk about this, but I guess the biggest things we have to consider are the first 3 points here, where we're going to have follow-ups. It's going to be animal behavior, there's human behavior, how well they're going to be able to comply, and then antibiotic considerations, the timeline of healing, and then the type of client and patient to do this on. I think those are all the important kind of bullet points that we need to expand on, right?
Yeah, and each case is individual, both the patients and the clients. As we've kind of highlighted, some clients are a lot better at complying. It's easier for them to comply than others. So you have to kind of get creative, I feel like, and roll with the punches, so to speak. Just take what you're given, do the best that you can. Just really over communicate with these clients as well from the beginning, set expectations, set yourself up for success, get that culture and sensitivity, make sure that you're using these grafts on healthy wounds. Otherwise, you're just asking to be set up for failure. So I think that the cultures are super important. I think that considering both patients and clients, and their abilities to do or not do certain things, or tolerate or not tolerate certain things, are all important. And I think that each case is unique, and I'm sure we're going to continue to have stories to tell in the future.
Well, thank you so much, Dr. Clark and Benikas, for sharing those complex cases using Kerecis fish skin. I'd love to chat more about your first case, Max. It's always so frustrating when dealing with incisional complications. So, were there any alternative treatments that you considered initially or when the incision dehisced, and why did you eventually opt to use the fish skin graft over the other options?
So yeah, that's a great question. Because of how swollen the paw itself was, like the surrounding skin in that area, if I were to try to do like a local advancement flap or something like that, was a thought that crossed my mind. I was just worried about the skin in the surrounding area. So I really I wanted to try to avoid using that. Doing like pinch or island grafts, I just felt like would take forever. Just the sheer size of the wound is really also kind of what drew me to the Kerecis graft, because I just felt like the pinch or island grafts would just take forever with this size of wound, and there just wasn't a good local alternative to pull skin from elsewhere on that leg.
And what did the histopath show?
The histopath did show was a grade 2 mast cell tumor, complete margins, fully excised.
That's great.
Yeah.
And I think that's a really good point is, if you're in general practice and you're doing wide excisions on distal extremities, you might not be comfortable doing grafts and flaps. And so if you want to go with the open wound management technique for closure of, mass excisions, that, the Kerecis fish skin graft plays a good role for those cases. So one of the questions from the chat was asking whether or not there are any contraindications to using the fish skin graft with dietary allergies to fish. And that's a great question. And there is contraindication to Kerecis with a whitefish allergy. And so the recommendation would be if there's a known fish allergy, you would avoid using the graft in those cases. That is a great question. So, Dr. Clark, can you maybe walk us through the procedure for applying the fish skin graft?
Of course. So what I do is, fully aseptically prep the limb. Usually by the time we get to that, there's been, some degree of chronic long-term open wound management. So sometimes there's fur that's regrown, definitely want to put like protective sterile lube on the wound, reshave that hair. I prefer with open wounds using like betadine as my prep, as opposed to obviously like alcohol or chlorhexidine. So we'll dirty prep, move into the OR, and then do our sterile prep. I do like to kind of freshen the wound bed, the granulation tissue. I do want to get it to where it is bleeding. I think that's an important point. And then when you take the acellular matrix out of the peel pouch, you do want to rehydrate it for like a minute or so in sterile saline. And then at that point, I typically will start shaping it to the exact contour of the wound. I like to use iris scissors to do that. And I kind of do it in a stepwise fashion where I'll start kind of maybe in what I think is the trickiest part to contour the graft to. And so I'll start contouring, put some sutures in, and then as I go contour more, put some more sutures in, kind of like a cut and sew, so to speak. And then I do like to put those slits in there to allow that, serous discharge to come through the graft and not like get trapped underneath. And then after, it's fully applied, again, I did not have a good experience with the hydrogel, but just dry Telfas have done really, really well. So just dry Telfa standard soft padded bandage. And I do like to, for the first 3 days at least, change it daily, that bandage daily, so I can see how much strike through and discharge we have, plus keep a close eye on the graft. And usually after like 3 days, we can transition to like every other day.
I do think that those secondary layers, or I guess technically a primary after the fish skin graft is, can be very tricky determining which layer to put on there, and it's very dependent on the amount of exudate coming from the wound. I have a particular favorite for using calcium alginate over top the fish skin grafts, and that's because I won't actually change my bandage very frequently. I'll often change it every like 4 to 5 days if I can stretch it, and then once weekly, because I found that sometimes you find that the graft sticks to your bandage when you change it, if it dries out or anything like that, which is why the hydrogel is a good thought,
Yeah.
And because you don't want it to stick to your bandage because it'll rip it right off.
Right. Right.
And so, yeah, and so I found that leaving it in place and just not disturbing the wound bed and using calcium alginate to absorb all that exudate was really helpful in kind of maintaining the moisture, but also the exudate that comes with that. So
Yeah, I could see how that would be beneficial for sure. Yeah.
Yeah, especially with a dog like Smokey.
Yeah.
To come in so much.
And so with cases where you had exposed bone or tendon, did you do anything different with your management protocol?
No, actually, I didn't. I just applied it just like I did, over our granulation beds, and noticed that, after applying it, there was granulation tissue that formed really quickly afterwards over those exposed bones or tendons.
Yeah, I've similarly had a few cases as well where you can just kind of place it right over there, and when you change your bandage next, it's covered with granulation tissue, so then you're happy you
Yeah,
don't see it anymore. Owners are
exactly. Yeah.
happy not to see it anymore.
Yes, it's always exciting.
What about with the paw pad sloughing? You had one case with the paw pad had kind of sloughed. Did you feel that there was any healing of the actual, pad itself, or did it kind of just get like that normal epithelial tissue over it?
So the case where it sloughed was max, and that was just secondary to the amount of edema in the limb. Um, it just healed on its own in his case. But I feel like in Casper's case, where he actually like had no paw pad left in some areas, he regrew actual paw pad tissue like that, the thick.
Keratinized.
Yeah. That, you can see in the pictures is distinctly different than the skin surrounding it. So I didn't know what to expect going in doing that, but was very pleasantly surprised.
Yeah, it's, when you're dealing with different tissue types, you're maybe not sure what will come of that, once you're applying the grafts, but it's, the body's going to regenerate the tissue in that area. So kind of, sort of makes sense, I guess, when you start to think about, okay,
Yeah.
we're promoting tissue regeneration in that area. So the graft,
Right.
the go back. Yeah. So, in your opinion, or after having used it on a few cases, have you noticed any differences in the tissue, the healing of the tissue bed compared to maybe other open wound management techniques that you've done in the past?
I definitely think that the cases where we've used the grafts have healed a lot quicker than similar cases where we just did traditional open wound management. Even like with Smokey, like I mentioned, his wound was smaller, and like we could have got that to heal with open wound management, but again, I feel like it would have taken probably twice as long. I feel like the wounds that we apply the grafts to heal really rapidly compared to the traditional open wound management cases that I've had that are similar in the past.
Mm-hmm. And so when it came to, for example, Smokey, how did you explain to the owners the use of the fish skin graft and like what was their reaction?
So I feel like all the owners, they always think it's super cool. I explained that, we're using this, sterilized, gone through processing, et cetera, using this to put on the wound to act as a scaffold to then promote healing, hopefully in a faster manner than we could get it to heal without the graft. And one thing I found is they always want to see pictures. And they love, even though the scales have been removed, you can see the little like indentation. They love seeing it, and so I think that they all have reacted very positively to it and think that it's actually pretty cool.
Yeah, they always like comment that their dog is now part of fish.
Yeah.
Yeah, they are usually very open to that management technique. I agree.
Yeah.
So let's talk a little bit about the cost of the graft versus cost of traditional bandaging techniques. So if we were going to look at just open wound management versus including the graft in it, did you see any cost benefit or, did the clients feel the grafts were expensive?
So Dr. Benitez and I were actually talking about this last night after we saw Smokey, and I feel like cost is always a concern with owners, and so when they see a price for the graft, they may think that it's expensive, but then when you explain to them, okay, my expectation is that we apply this graft and the amount of time that it's going to take to heal is going to be shorter, and so you're going to have less follow-up visit costs, bandage costs, less gas to get here, less hassle bringing your dog or cat. And I feel like we were talking last night, it would have been at least as expensive, if not more expensive, for Smokey to have done just open wound management and healed just by traditional open wound management.
Yeah, and I mean, and that's if we had charged the full cost, because in his case, it was kind of a compassionate use of the graft material.
Mm-hmm.
We didn't charge the full cost of it, but if we had, it still would have cost more, I think, for open wound.
Oh, for sure.
For sure.
And what's your favorite lavage solution to use when managing these wounds?
So at first, like when doing open wound management, I do like to use betadine, like a dilute betadine. Once I've applied the graft, I typically try not to touch it very much, just minimal. If anything, just sterile saline. Especially don't want to be like really rubbing it a lot with gauze or anything, just very gentle cleansing. But I try to keep it to a minimum.
So I really appreciate you taking the time, Dr. Clark and Benitez, for sharing your cases with us.
Thank you. We're happy to share.
No problem.
Thank you, Dr. Maxwell, Dr. Clark, and Dr. Benitez for a wonderful presentation and for the conversation with the audience and answering the questions. And to our audience, together with the doctors, we want to thank each and every one of you for your curiosity, for signing up and taking the time to join us in the fish tank. And we hope you enjoy the presentation and that the cases that the doctors share are helpful to you and to your patients. If you would like to explore cases further or would like additional information, I think my email address is on the upper corner was on the last slide, but it's mhines@careassist.com. Or if we didn't get to your question during the presentation, please feel free to email us and we'll be happy to answer to you. Thank you, everyone, so much, and we wish you a happy Thanksgiving. That's coming up very soon.
Thank you.
Thank you.
And thanks to all the technicians and Dr. Ware and all the other people that helped us with our cases.
Thank you so much. Happy to see you guys.